Well, good morning. It's my opportunity to talk to you again about the recent board meeting that we've just completed earlier this week, and some of the issues that were covered in that. As usual, we first talk about fairly general issues and follow up on actions from the previous meeting, and one of these was to look at our food, and generally it's perceived that our food and the quality of our food and the service that patients are getting and our staff around food is pretty good, and certainly seems to be better than in some other areas, but we're continually looking to improve that. There have been a few complaints recently, and so we're looking at some options around improving the menu further. So that's going to be interesting over the next few months and working with that. Kind of strange to start a discussion on board meeting with food, but that's how it did start. We always have a number of patient stories, and we balance good stories with bad stories, and usually have a couple of positive stories and a story where things didn't go so well for a patient, and then the board's very clear that they want to understand what learnings we've had from that. So we did have a interesting patient story which I won't share the details of, but certainly it was a credit to the ED service, because this patient was not your average patient who, I guess, garners plenty of sympathy in the ED and throughout the service, but was a methamphetamine addict, and they felt that they were treated very fairly and really appreciated the fact that there was a non-judgmental approach to that person's care. So that was a nice, interesting, positive story, and shows the quality of care that we are providing within our ED. A negative story was a patient who had received surgery funded by the DHB but outsourced, and we're having to outsource quite a bit of surgery to the private sector because of our lack of theatre capacity at the moment. And this patient found that when they had a complaint and an issue to deal with, it was very unclear who they should be seeing, because they'd been treated in private but were still a public patient. So we've worked out a pathway which ensures patients who are in that situation know who they should approach. We had the usual review of our quality and safety report and the results of the various patient surveys that we're doing all of the time. And also looked at some of the quality markers that we report through to the Health Quality and Safety Commission, as well as some of our CRAB and Health Roundtable data, which is providing a lot of useful information around quality and safety of care. And in general, we're doing very well, but it also points to areas where we can focus on and improve. As always, we also covered off the progress on a number of our strategic initiatives, some of the things we're trying to do around investing upstream, and more importantly changing the system upstream to try and not only improve population health and reduce inequalities and improve equity of care, but also, and access, but also it's also about a number of other initiatives that we're doing to try and make sure that the hospitals that we are spending, of course, so much money on and so many of our staff are employed in, are not receiving patients that they don't need to receive, and as much as possible we're managing the acute demand. And I know at the moment that feels like a real challenge, and that this may not be achieving its goal, but of course we're working against quite a I guess a perfect storm of difficult and challenging issues. The first being the significant population growth, and I'm sure I've talked about this before, and also our rural population, our ageing population, high Maori population, and the poverty within Northland. All of those, of course, make it a great place to work in health, because you're going to make such a difference, but it's also really very challenging because we are getting very sick patients who are being seen at times far too late in their progress of their illness. And so we are wanting to improve that as much as possible, and the only way to do that is to be working out in the community as well. We had a discussion about some of our place-based initiatives. What used to be called social investment is now called social wellbeing, and this is where we're working with high-need families, children, youth, and we have up to 6,000 of those youth and children in Northland that require particular interventions and care, and we're focusing on 3 places within Northland at the moment. That's Otanerei, Kaikui, and the far north based around Kaitaia. So some interesting initiatives going on there within the community. A good discussion on our challenges with our theatre capacity, and a discussion on access to joint surgery, and an initiative that's being explored at the moment. There's been no decisions made, but the opportunity to do some less complicated major joint, that's hips and knee surgery, up in Kaitaia, which if that pans out will be a really positive initiative and provide us with a little bit more capacity. We have I guess it's an IT initiative, but it's much broader than that. It's actually a system change initiative. It's called the Collaborative Community Care Project, and it is based on the replacement of our JADE system, which is used for mental health and community services at the moment, and we're looking at the opportunities that presents around a health record, which can be used much wider than just mental health services and community services. Could involve primary care, and certainly there's interest across the whole region, that is all of the Auckland DHBs as well, and so we have senior participation on that. We have to replace the system because it is completely unsupported in 2020, and in fact the vendors are moving out of Australasia, so there's no way we can go past that date, and so this is a fairly tight program, and procurement process is being discussed at the moment, and we're looking at various options there. So a really, I think, exciting, could be transformational project around our information systems, which, as you know, have plenty of room for improvement. We've also discussed a number of other things that are going, I think, really well. There's a mobility project with our public health nurses where they're using iPads and mobile devices to care for their patients out in the community, and obviously we've also got a number of initiatives where we're wanting to improve the use of mobile devices within the hospital. Some fundamental other improvements need to be in place first, so we're trying to work through those. All of these initiatives have only been enabled by us replacing our patient administration system, which was critical to all of this, and building some stability in our systems. If you remember, 2 or 3 years ago, we were having weekly, if not daily, crashes of our systems. I think things are much better than that now, and I know we still have some challenges. We also talked about a couple of RMO improvement projects. 2 of our RMOs spent some time in the previous quarter, and we're allocated that time to look into a couple of improvement projects. We're provided with training around improvement science, support from Claire Woots, our own Director of Innovation, Improvement and Excellence, and also the RDA, and these projects were I think really useful. I listened to the presentation on them recently, and one was around handover and improving the handover process for RMOs, and that's really worthwhile. And the other was around improving prescription and the ability to make sure that there's a continuous scripting process, particularly for our patients that are in for longer than 7 days. So Cameron and Michael did a really good job with those projects, and we're looking at doing that again later in the year, and we are offering other staff opportunities around understanding and learning improvement and wanting to really drive that culture of wanting to improve. And you see the problems that you have within the organisation, and I'd just love it if more and more of you were able to go about solving those. And I recognise that takes time, and you need to be given time, and it also takes skills to make the right decisions, because often we can see a problem and we jump to a solution, but that can have other unintended consequences. So it's pretty important that you go through the right process around testing, planning something, and studying it, then doing something about it, and then reviewing that. So that process, that cycle of PDSA is really important within improvement, and there's a lot of tools that are used in improvement. So we're wanting to train and support more staff. In fact, over the next year, hoping to have about 300 of our staff go through some training, and many of those hopefully will have more extensive training as well. So we want to support you with time and also the skills to be able to do those sorts of projects and just make things better for yourselves and for patients. We as always, every 3 months reviewed our bad debts. And why do I mention those? We do have bad debts, and those are a mixture of really two things: either patients and overseas patients, non-eligible patients that don't pay their bills, or equipment, and equipment goes missing at an alarming rate. And in fact, this month, or this quarter, equipment loss exceeded the cost of overseas patients, which is unusual. Usually our overseas patient bad debts are significantly more. This is not still, relative to our $650 million budget, a big amount, but over a year we usually have about $200,000 of debt, and so this month was slightly lower than that, lower than that quarter that we normally would have, around $50,000 or so a quarter, but a significant amount of it was based on equipment. Obviously crutches we all know about, but interestingly there were about 4 rather expensive wheelchairs that have gone missing. So we are looking at whether we can track those with GPS tracking, etc., or marking in some way to ensure we can get those wheelchairs back. Obviously we do go to the debt collectors, and they do try and recover as much as possible. So just an interesting point which comes up every 3 months, and there's usually a little bit of discussion about that. In the public excluded meeting, we go into discussing risks and a number of contracts that may be needing approval, which are confidential, commercially sensitive, etc., and or discussing any other issues which really aren't appropriate for the public arena, and there's quite clear criteria around that. But some of the risks that we discussed were regarding Whangaroa Health Services Trust, which is really struggling at the moment from a governance, financial, clinical sustainability point of view, and this is a relatively small, high-need community. One of our original communities that had a special status, so Hokianga and Whangaroa were the 2 communities, and they get free primary care services, and so this is only a 3,000 population community, and so we're looking at options around sustainability of services for that community, particularly primary care, but also their aged residential care service. We had a discussion about the new initiative through the government around funding of primary care going forward, and the reduction in cost for patients with a community service card who aren't currently accessing the very low cost access services. So flagged to the board a few risks with that, also the opportunities that are coming through around that project, which the Minister has announced will be implemented in December, and that involves over $100 million going into New Zealand primary care, which is a really positive thing. We discussed rest homes a little bit and some of the challenges that they are having, and particularly where there are issues around quality. Most of our rest homes provide really superb quality of care. And of course we discussed the nursing negotiations and the recent strike and the contingency planning at length, and the contingency planning went very well, I'm glad to say, but we also obviously discussed issues around the negotiation of etc. So always very hopeful that we'll get a resolution for that really difficult issue as soon as possible. And we also discussed our end of year financial position. At this stage I can't share that with you, but we certainly have posted a deficit, a significant deficit as was expected for this year, and as you know that was partly due to the 3 years previously having less funding than we should have been receiving, and having a capped funding, and that's amounted over these last 3 years to $29.5 million. But it's really highly likely that Northland's been underfunded for many years before that, because with the 2013 census we discovered another 6,000 patients that hadn't been counted prior to that, and so that represents about $20 million in itself. So significant funding that probably for 10, 15, 20 years has not been going into Northland, and obviously with our extremely high need community that's a critical issue, and it does put us somewhat behind the 8 ball. Government has and Ministry have addressed that now, but as I said, that's still having an impact across our services, and I'm very aware of that. We had a discussion about Te Ara Oranga, our methamphetamine demand reduction program, and the risks around funding and how we can ensure either sustainable funding or a longer term funding path, and there's work going on regarding that, and it's been in the media. Certainly we're still very hopeful that the Proceeds of Crime Act and its fund will fund this for a period to come, so that we can really evaluate what is an incredibly innovative and positive project, and an awful lot of people have been very heavily involved in that. But it does require external funding at this stage. We every year write and complete an annual plan. It's a contract with our Minister and the Ministry. It reflects the Ministry and Minister's priorities. It also reflects many of our own priorities, and we try to ensure any other initiatives outside of those priorities are included in that plan. So the Board approved the first draft of that, which is going to the Ministry in late July, and we'll get response and feedback from them, and then a further version, a final version, will go to the Ministry later in the year. We also discussed at length our Whangarei Hospital campus redesign, and business case will be coming to the Board next month, and that business case will basically outline the options for a rebuild on this campus, and a preferred option, and it's called a program business case. So that's the second stage of quite a long business case process, but we're then, once the Board has approved it, it will go to the Capital Investment Committee, and the process will continue over a period of time as we work towards getting approval for a new hospital. And I think all of us know how necessary that is within Whangarei. Speaking of which, we're now at over 3,000 staff, so each year for the last few years we've grown at between 60 and 100 staff. This year over 100 extra staff have been put in. Believe me, nearly all of those are clinical roles. They're always, and we are always, playing catch up, and I recognise the growth in our services, both new services that we need to provide and want to provide within Northland, as well as the demand on our existing services and the growth in numbers, and so that's a real challenge for us, and we're doing our best to keep up with that. As I've said before, we're going to struggle to be able to house everybody as the years go by, and we're looking at a few years before we will get a new hospital. So we have to look also, as well as putting in more staff and making sure our staff are safe, and we're very keen to ensure that as well. You know, this year we improved a significant amount of money for this coming year for CCDM project and expansion of our nursing staff from a safe staffing point of view, but there's also a lot of other areas and a lot of other professions where there are challenges around staff, but we also need to be looking at how we can do things differently, more efficiently, more effectively. Are there new models of care that we can explore, and what's the best practice internationally and within New Zealand? How do other DHBs manage these things? So there's lots of things that we can do, as well as the increases in staff that we're putting in. And obviously with that goes requirements for more car parking and everything else that you see with that, and I think we've just hit capacity around car parking, and so are exploring options there. These last points were not in the board meeting, but I thought I'd tell you about them anyway. So that's pretty much it for me this month, and thanks for listening. I hope there's been some interesting information for you and you found it helpful, and I'm really just trying to make sure that you're understanding the whole picture and all the issues that we face, not just within your own services. So go well, and hope to see you around the hospital at some stage or within your various other areas, and I'm really hoping that over this winter period you stay healthy and flu free. Thank you.